Welcome to Plastica Review. We're going to go through the latest papers on aesthetic plastic surgery of the breast for the month of May. And the first one is an international review on 40 government authority databases regarding the global adverse event reports of breast implant associated ALCL. The authors found out that there were 258 unique cases as of September 2015. Out of these, the majority of cases were on textured devices, only 4% on smooth wall devices. They also reported that none of these cases appearing in smooth surface devices had a complete history, noting that we don't know whether they had or not textured devices before. I think the most interesting conclusion about this paper is that there's definitely an underreporting of this disease at the moment. There's definitely not enough communication between the government authorities and the physicians and the scientific societies regarding the communication of these diseases or these cases. No, they put a couple of very good examples about this lack of communication between the authorities and the scientific societies. For example, the case in the Netherlands where there was a published paper in 2008 with the first 5 cases in the Netherlands of breast implant associated ALCL, and the Dutch agencies had 0 cases reported when this manuscript was being prepared for PRS. And a good example is Spain, actually, where my practice is, where the agencies initially reported no cases of breast implant associated ALCL, and we know in our society that there are 16 documented cases and another 9 pending confirmation. So I think this paper points out that there's definitely this lack of communication between national ministries of health and the physicians and the scientific societies that are more aware of these cases. Now, I think this is changing now. I think that there's definitely been more emphasis on improving this communication, and there's different task forces in several countries, and this will change definitely in the near future, and we will have a better knowledge of the real incidence and prevalence of this disease. And the other paper regarding breast implant associated ALCL, also signed by Mark Clemens and colleagues, is on the US epidemiology of this disease. And in this paper, the objective is to really find out the true incidence of this disease in the US. And to do that, Mark Clemens has been able to identify the exact number of textured devices in the US, and he has disregarded all other types of devices since he has argued that really it's a textured device disease at the moment, breast implant associated ALCL, and he is able to come up with an incidence that he estimates on 1 in 30,000 patients. So really finding out that it is a higher incidence than initially thought in the US. And there's a very good discussion on this paper by Anand Deva from Australia, where the incidence has been estimated to be between 1 in 1,000 and 1 in 10,000, so even higher than in the US. And he really describes very well and very schematically what we know at the present moment about this disease, and I think it's also very much worthwhile read. And the next paper we're going to discuss is yet another paper dealing with the difference between round and shaped implants and the lack of advantages of either one with respect to the outcomes. This time on reconstructive surgery instead of on aesthetic plastic surgery. And this is actually a multi-institutional paper. It is signed by John Kim as corresponding author, and it shows no difference in patient-reported outcomes between round or shaped implants for breast reconstruction. In terms of other findings, they did show that round implants had a slightly higher incidence of revisional procedures on the contralateral breast, and they showed also that shaped implants carried a higher risk of the need to administer IV antibiotics postoperatively due to a higher incidence or possible incidence of infection. Regardless of these differences or these findings, the really important part of the study regarding patient reported outcomes really showed no difference or no advantage of shaped implants versus round implants with regards to breast reconstruction. And this is similar to a paper written by Jessica Gam and colleagues, a Swedish paper from November 2010 in PRS, where they also showed in reconstructive patients no difference between shaped or round expander devices in terms of being able to distinguish which of the patients had a round or a shaped device. The next paper by Venkat Rao and colleagues, it's a level 1 study, a prospective randomized controlled trial regarding the use of lidocaine in breast reduction. And they showed in their study that there's really no advantage of adding lidocaine to a tumescent solution for breast reduction in terms of not achieving, showing it does not affect the pain the patients will have postoperatively. It does not either reduce the need for pain medication postoperatively, and it also doesn't decrease the postoperative nausea and vomiting due to a possible advantage in terms of not needing as many narcotic drugs these patients postoperatively. So a very well carried out paper, of course, level 1 study, and maybe we should think twice next time before adding lidocaine to our breast reduction procedures. The next paper is a great study, is by Nathalie Kerfant, Eric Leclerc, and colleagues from France on the combination of fat grafting and subfacial breast implants. I'm very happy that they cited my work also on this combination of fat grafting and breast implants in the Paris-Saône region. And they show, of course, that the use of fat grafting really provides an advantage in breast implant based augmentation, especially in terms of avoiding separated breast deformity and improving the cleavage area. Definitely important work by really the inventor of the technique, Eric Leclerc. So great study. Another nice paper is the one signed by Nina Mary King and colleagues from Australia regarding how much volume is necessary to increase one bra cup size in breast augmentation. And of course, they start out by pointing out that not all bra sizing methods are similar between countries and even between manufacturers. So there's a big discrepancy between what a cup C or a double B or a double C is between bra manufacturers and of course between countries. They end up stating that they have calculated that it is necessary to increase between 130 and 150 cc's the volume of an implant to increase one cup size in the size of the bra, which is more than what was initially thought. Initially, it was thought that just with 100 cc's you could increase one cup size. So I think it's a very worthwhile read. And the next paper is by Jeffrey Gusinoff from Pittsburgh and colleagues regarding the challenges of augmentation mastopexy in the massive weight loss patients. And of course, we all know that these patients have a more difficult approach. They have excessive skin and normally lax tissues. So the authors really point out, the key parts of the technical nuances that should be carried out in order to achieve better results. Basically, they point out things such as removing more skin that you would normally do for other types of patients, and also trying to add some sort of maneuver to fix the inframammary fold to the chest wall so it doesn't migrate. There's a very good discussion of this paper that is really pointed out that it's also a good adjunct to use a dual plane, of course, to improve results in these patients, which actually are more difficult to achieve good long-lasting results. And moving on to ASJ, there's a very worthwhile paper written by Varun Gupta and colleagues from Nashville, Tennessee, regarding the incidence and risk factors for major complications in 73,000 patients undergoing cosmetic breast surgery and concomitant procedures. Now, this is a very clever study because they actually acquired the data from an insurance company, Cosmetasure, which insures patients on unexpected major complications appearing in the first 30 days post-operatively. And that's how they were able to acquire such a large number of patients in their study. They found out, of course, that the incidence of these major complications is very low after breast surgery procedures. Only 1.46% of the patients overall experienced major complications in the first 30 days. And they found out, for example, that the most frequent complications were hematoma and infection. They saw that augmentation mastopexy had a higher incidence of complications, especially infection, than breast augmentation alone, and that when any breast procedure was carried out with an abdominoplasty, the risk of complications increased. They found that age was a risk factor for hematoma, and both age and BMI were risk factors for infection as well. And there's a very good commentary on this paper by Alan Gabriel and Patrick Maxwell, really pointing to the fact that the study only includes major complications appearing in the first 30 days post-operatively. That required a visit to the hospital, and they argue that, of course, there are many more minor complications that may be resolved in the office and other complications that appear later on after the first 30 days. That should be taken into consideration when evaluating the overall incidence of complications after breast surgery procedures. The next paper in ASJ on breast surgery is by Hilton Becker and Nicole Fregosi, and it deals with the impact of animation deformity on the quality of life of post-mastectomy breast reconstructed patients. And it points to the fact that submuscular breast reconstruction will carry some degree of animation deformity, and that this animation deformity will affect the quality of life of these patients. It comments on the classification of animation deformity by Scott Spear, which is well known, and tries to emphasize the need to address this issue in order to improve the quality of life of patients undergoing breast reconstruction. Now, there's a very good discussion by Mark Magnuson on this paper, and of course he points to the fact that animation deformity can be minimized even in the submuscular plane, especially doing some sort of dual plane procedure, and of course also using smooth wall implants and releasing the muscular attachments medially of the pec major can greatly improve animation deformity. And actually he shows a very good video in this commentary with an excellent result in the submuscular plane for a reconstructed patient. So definitely a very, very interesting read, both papers. And the last paper on breast in ASJ is by Paolo Montemurro and colleagues from Sweden, and it's on the use of capsular flaps to improve lower pole support in revision breast surgery in what they have termed autologous collagen matrix, ACM, in a clear reference to the alternative to improve lower pole support, which are ADMs, acellular dermal matrices. And again, I think this is very good use of the capsular tissue to improve lower pole support. It has been, and the authors do reference very well previous authors that have also employed capsular flaps to improve the lower pole support in secondary breast surgery. And of course, you have capsular tissue that can be used as a matrix or a support for the lower pole without the need to use ADM, since we already have all that tissue and collagen that can provide excellent support in secondary cases. And that's all on aesthetic breast surgery for the month of May 2017. I hope to see you all next month on Plastic Art Review. Thank you.